uh, welcome to this 83rd webinar on COVID-19, which is being organized by Andhra Medical College for over 1 year now. And we are discussing the topics of contemporary interest. And as the cases are rising in America, and we see that we might have a similar situation here in 2 or 3 weeks to come. So we are balancing the topics in such a way that we are dealing with the COVID, post-COVID problems as well as acute COVID problems. The thrombosis in COVID-19 continues to be a topic that needs a lot of discussion and have regular protocols so that we all follow the same norms with good outcome. And as you're all aware, Dr. Kairam and Dr. Sridhar Chilumari have taken this Herculean task of keeping this discussion very lively over the weeks and months. And Dr. Kalpalata Guntupalli has been very kind enough to come forward, not only offer her comments, but also have a lot of speakers from her department and from amongst her students. So today I'm very happy that Dr. Mani Lagad has accepted to talk on COVID-19 and the anticoagulants that need to be used in acute phase. And I'm equally glad that Dr. Ravi Sharma has accepted to moderate this session. Dr. Ravi Sharma is very close to our hearts here in Andhra Medical College. He is not only a great human being, but an extraordinary professional. And he has been instrumental in upgrading the institute by his benevolence. And with these few words, I welcome each one of you to this session. And I would request Dr. Ravi Sharma to introduce Dr. Mani Lagad.
Thank you so much. I'll take just a few minutes as we are accumulating audiences. We are at about 85 right now. So this is a real pleasure for me to participate here. I want to thank Sudhakar for this extraordinary effort and in a successful one for doing this close to 14 months. I don't know of any other institution that has been able to do this this consistently and this successfully. And as he mentioned, Ram Mohan, Sridhar, and our close friend Kalpata Garu, Prasad Chalasani, Andhra Medical College Alumni Association have been very instrumental in keeping these discussions very diverse and lively. So I will digress a couple of minutes and then talk a little bit. When I came to United States, I had several offers to choose from, and Dr. C.R.R.M. Reddy told me, Ravi, you go to Chicago. So I went to Chicago, went to Cook County Hospital, did my residency there, came to Emory, and then went back and then came back. So the trajectory I used, I came back to Atlanta in 1979 and stayed there for the next 40 plus years. 17 of those as faculty at Emory in the Division of Hematology Oncology and 25 years in private practice. And then in 2019, I left Emory and came to Washington, D.C. to be near my daughter's family. And Harvard University asked me to join their faculty, so I joined them. So the connection to Andhra Medical College and Emory goes long and deep. Babu Bangaru, which many of you know, Sudhakar Babu did his pediatric GI fellowship there. Jayasri Garu, Rajasri Garu, his wife, did pathology there. I did my oncology fellowship. Prasad Chalasani did his residency and fellowship at Emory. And one of my seniors, Nuka Bhaskara Garu, he is a gynecologist in Chicago. His son, Ajay Nuka, is an incredibly well-respected myeloma researcher at Emory. You will be hearing from him in the near future. So that is the connection between Emory and Andhra Medical College. They understand Andhra Medical College well, and we like Emory a lot. It's a national institute. Used to be a regional university, but it's about 100 plus years old. The connection to Atlanta and India is again incredible because of Martin Luther King. And in 1983, we created the connection Gandhi and the King celebration. P.V. Narasimha Rao Garu was External Affairs Minister at that time, and we hosted him. And eventually, we had a Gandhi statue put in at the King Center, and that was done through our initiative in Atlanta. So, what does it all have to do with Manila Gad? She followed a path that is familiar to me and now familiar to all of you. She trained at Lady Harding College in Delhi, came to county, did her residency there, and did a fellowship in oncology. When she was a fellow in oncology there, her division director was a close friend of mine, Tom Ladd. Tom and I trained I did part of my fellowship at University of Illinois, and Tom and I were oncology fellows together. And we kept up our friendship due to our interest in lung cancer and pharmacology. And he was a division director, and he trained her. And then in 2012, Manila came to Emory and joined the Emory faculty. In the last 10 years, she created a very fantastic hemostasis, coagulation, hematology, and also that spectrum includes hemophilia. Her publications include work on leukemia. And she put together the protocols for COVID thrombosis. And so we have several common colleagues that have been, that she works with that I have known over decades. She's the director of the hematology at Emory Consultation Service at Emory University Hospital, and also at the Emory Midtown Hospital, which used to be called Crawford Long Hospital. Dr. Crawford Long was the person who was credited to giving general anesthesia for the first time in the 1830s. And he's the lead thrombosis physician at the Hemophilia of Georgia Center for Bleeding and Clotting Disorders at Emory. As a member of the Venous Thrombosis Thromboembolic Research Network of US, is called Venous. She is involved in multi-center trials in thrombotic disorders. So with that extended introduction, I would like to ask Manila to take over and treat us for an evening of COVID and thrombosis and all the intricacies and the nuances. Thank you so much, everyone.
Thank you, Dr. Sarma, for that kind introduction. And I want to thank and congratulate all the organizers for this incredible endeavor of exchanging knowledge, exchanging ideas. This is really incredible and the first of its kind that I have heard about. I feel honored to talk to this audience that is here on a Sunday morning at 6:30. I mean, this is commendable again. So thank you all for being here. With this, I am going to start this discussion on COVID-19 and thrombosis, and I look forward to exchanging ideas with the audience. These are my disclosures. And this is going to be the format for today's talk. I'll start with discussing the pathophysiology of COVID-19 associated coagulopathy, then move on to discuss the management of this coagulopathy as we understand it right now, and then touch upon a topic of interest that has come about from the use of vaccines, which is vaccine-induced thrombotic thrombocytopenia. So we know that symptomatic COVID-19 infection is associated with a distinct coagulopathy, which is characterized by just mild thrombocytopenia, mild elevation of prothrombin time, marked elevation of fibrinogen, and D-dimer levels sometimes reaching over the measurable limits of our lab assays, especially in patients who are critically ill, right? An increased risk of thrombosis. Overt DIC, that means disseminated intravascular coagulopathy, with characteristic bleeding phenotype is rare, and it is limited to late stages of the disease. Now, several observational studies, and mainly retrospective studies, they have looked at association between markers of coagulopathy and clinical outcomes, meaning why is it important for us to pay attention to coagulopathy? Right? What they found was thrombocytopenia and elevation in D-dimer levels they were consistently associated with poorer outcomes, with need for mechanical ventilation, with ICU admissions, with deaths. So this indicates that coagulopathy is associated with poorer outcomes. The more severe the coagulopathy, poorer the outcomes. Now talking about the burden of thrombosis in COVID-19 patients. So most studies reporting on rates of thrombosis are retrospective studies, and they are from mainly the ICUs. The reported rates ranged from 16.7% to as high as 69% in the study from France, where they have an established protocol of just screening everybody who comes to the ICU with ultrasounds. So again, what that tells us is if you go looking for them, then you will find more and more clots in these patients. There are two studies that I have quoted here, which actually compared the incidence of clots in COVID-19 patients. One compared it with contemporary non-COVID ICU patients, and the other compared it with a cohort from the previous year, before COVID-19 came about. And they found that clearly COVID-19 patients do have a higher risk of clots than non-COVID-19 patients. As far as laboratory predictors of thrombosis are concerned, now this multi-center retrospective study from Boston, Massachusetts, they compared markers of coagulation and inflammation between patients with and without clots. Just as an aside, they also looked at patients with and without bleeds, but just focusing on clots here, they found a very interesting correlation between markers of inflammation. CRP, ESR, ferritin, D-dimer fibrinogen. So these markers of inflammation were associated with patients who developed clots. Right? So this brings us to this important concept that can explain much of what is happening in COVID-19 coagulopathy, and that is the concept of thromboinflammation. So in essence, the body's inflammatory and coagulation systems are both activated in a coordinated manner as part of a defense response in the beginning to various infectious and non-infectious stimulants that I have mentioned here in the slide. So what the body is actually trying to do is it's trying to fight the infection, for example, and limit this insult and prevent its spread in the body by activating both the inflammatory and the clotting systems. So there is increasing recognition of this functional interdependence between these two systems, whereby inflammation stimulates thrombosis, which in turn promotes further inflammation. So what starts as a defense response can result in organ damage if it goes unchecked and if it spreads systemically. At the microvascular level, this thromboinflammatory response is characterized by actually obstruction of the vessels by the cellular components of the blood themselves, or once a fibrin clot is formed, there's more stable occlusion with that fibrin clot. And a central feature that I want to mention here of this thromboinflammatory response as a whole is endothelialitis. So the normal endothelium, as you all know, has important anti-inflammatory and anti-platelet, anticoagulant properties, right? So it is postulated that SARS-CoV-2 virus, it binds to host cells through the ACE2 receptors. And these receptors are found in many organs, heart, lung, but heavily also present in the endothelium. So the binding of the virus to the endothelium through these receptors causes endothelialitis, which then damages these natural anti-inflammatory and anticoagulant properties of the endothelium, thereby increasing the risk of clotting. So to sum up here, COVID-19 associated coagulopathy, it can be modeled based on this famous Virchow's triad, where endotheliitis plays a central role, and this accompanied by flow abnormalities and activation of various components of the clotting system, it results in clotting, which further promotes inflammation. So just switching gears here. So now we've established that COVID-19 is associated with this coagulopathy. What do we do? What's the best way of managing this coagulopathy? Right? So very early on, this report from China became available. This was a single center retrospective study which compared mortality in severe COVID-19 patients who received or did not receive heparin thromboprophylaxis. 449 patients were included in this analysis, out of which 99 had received heparin prophylaxis and for 7 or more days. And they stratified these patients according to the SIC score, which is sepsis-induced coagulopathy score, which actually, the higher the score, that means the more severe the coagulopathy and the clinical illness. Okay. And they also stratified using D-dimer level. And the main finding that came out from this was patients who had a high SIC score or who had a D-dimer level which was greater than 6 times upper limit of normal for their lab, they derived benefit, survival benefit, with the use of heparin. Since then, a lot of observational studies have been reported, and I'll mention a few of those here. And mind you, these are observational studies I'm talking about. So this one came out of New York, where they looked at association of treatment dose anticoagulation with in-hospital survival among hospitalized patients with COVID-19. Again, a single center retrospective study, but the number of patients is higher here, 2,773 patients, 28% of which who had received therapeutic anticoagulation. And they report actually a survival benefit, again, with the use of therapeutic anticoagulation, more so in patients who were on mechanical ventilation, meaning again, in the more seriously ill patients, right? But this study actually was fraught with serious limitations. The biggest one was immortality bias. And this kind of became a talk of the town at that time when this study came out. Because patients to get therapeutic anticoagulation, patients had to survive a few days, because a lot of these patients did not start therapeutic anticoagulation until a few days into their hospitalization. So the patients who died early actually got characterized into non-therapeutic arm automatically, right? So that's why this study, it was really that this bias that this study carried was severe. And the authors did try to address that later. But, again, retrospective studies do come with their limitations like this. So then this multi-center observational study came about from 67 hospitals in USA. So this is not a single center study, this is multi-center, and over 3,000 patients were included. Again, they compared patients who received therapeutic anticoagulation against those who received no therapeutic anticoagulation. But this time they only included patients who had started therapeutic anticoagulation within 2 days of admission, right? And this study found no difference in outcomes between the two arms, right? So that's the kind of data we've been dealing with when it comes to use of anticoagulation in COVID-19 patients. Recently, the results of these 3 different randomized trials that collaborated came together and kind of, accumulated patients from all these different trials by synchronizing their protocols. So the interim results of these 3 randomized trials now came about very recently. They were published very recently. So they look at COVID in patients. It's a multi-center international randomized controlled trial, so better representation of patients from different geographical areas. So they stratified patients into severe and non-severe or moderate COVID. So severe meaning requiring ICU level of care, and moderate meaning requiring medical floor level of care. And they further stratified the moderate cohort into different strata based on D-dimer levels. Okay? And the arms they compared were prophylactic or usual care against therapeutic heparin. The primary outcome was survival to discharge and days free of organ support. And organ support, what they meant by that was any support for respiratory or cardiovascular system, meaning use of high flow nasal cannula, CPAP, BiPAP, or ventilator, ECMO, use of pressors. Right? So they compared these outcomes in the 2 groups. Then they had some secondary efficacy outcomes, which were clots, and a safety outcome of major bleeding, as defined by the International Society of Thrombosis and Hemostasis definition. And this is what they found. In moderate states, that means floor patients, therapeutic dose was superior to usual care venous thromboprophylaxis. And this was superior with regards to organ support free days. It was superior with regard to survival at discharge. And major bleeding in both the arms was low, 1.9% in the therapeutic arm versus 0.9% in the usual standard thromboprophylaxis arm. In the severe state, therapeutic heparin actually did not improve any of the outcomes, the primary outcomes. Okay? In fact, there was an indication of harm with therapeutic heparin in this group. Major bleeding again was low, and they did not find any significant difference, statistically significant difference between the 2, but the trend was higher in the therapeutic heparin arm. But then again, there are some limitations which we have to talk about with these randomized control trials as well. Right? For example, in the severe cohort, 51% of patients who were randomized to standard prophylaxis actually received intermediate dose anticoagulation. Similarly, in the moderate cohort, about 20% of patients in the therapeutic arm did not get it. Right? So, has the effect of each arm been diluted because of this? Possibly. Now, one of the 3 trials that came together in this, they even had an antiplatelet arm, right? So how do we account for that? Kind of things to keep in mind when we talk about this data. And on top of that, results from other randomized trials that have been reported so far, they're not really in sync with the results of these trials. For example, ACTION trial from Brazil that looked at prophylactic versus therapeutic anticoagulation in all comers, all hospitalized patients, I mean. And the therapeutic arm even had a post-discharge prophylaxis included in that arm. They didn't see any benefit of that. Both the arms did equally well or bad. And then the Inspiration trial from Iran, which was looking at intermediate versus prophylactic dose in ICU patients, again found no difference between the 2 arms. Right? So how do we reconcile the data? It is difficult, it is challenging, and I will share some practical challenges that our ICU folks and our internal medicine hospitalist folks have discussed with us. And you have probably also seen this in your practice. A lot of patients who are admitted on medical floors, they do well and go out, right? And so to put all of them on therapeutic anticoagulation and worrying about bleeding in those patients, when our hospitalists are not comfortable with that idea. And then, how about a patient who gets admitted and within a day requires the ICU? So you put them on therapeutic anticoagulation and then you worry about harm in the ICU setting. Like, how do you practically make sense of this data? It is challenging, and it has been very aptly described in an editorial that I just read in the NAGM that came out along with all this data. And that is, if you think about anticoagulation in COVID patients, what is the right level? The jury is still out, right? So what I'm going to share with you in the next few slides is what we did at Emory and what algorithm we're following. And I'm hoping some version of that algorithm you will probably find useful in your practice as well. I'm sure there will be adjustments based on your experience, your practice there. But I'm just hoping, you may find some version at least useful. If not, I do want your feedback so we can improve the things here as well. So, very early in the pandemic, around March of last year, what we did at Emory was, the work that I'm going to share with you is no one person's work. We kind of convened a group of folks who had interest or expertise in thrombosis from different medical specialties, which included pulmonary and critical care, of course, anesthesia, pathology and lab medicine, hematology, neurology, vascular surgery, cardiology, nephrology, pharmacy. So all of us got together. We reviewed the literature that was available there, literature from other medical illnesses that are as severe as COVID-19, and we kind of brainstormed strategies for preventing and treating clots in this illness. In early April, we came up with an algorithm where we had a 3-tiered approach that I'll share with you. But we do continue to meet regularly, and we have revised our algorithm from what it was in the beginning to what it is now. We've had multiple revisions based on new data that became available, experience that our hospitalists and ICU folks shared with us. So this is our 3-tiered algorithm that we are using at Emory. So level 1 or standard prophylaxis, this is for patients who are at lowest risk of thrombosis. So patients who are on medical floors with a D-dimer level less than 6 times upper limit of normal, and folks who have no clinical or radiological evidence of clots. So for this group, what we do is just a regular prophylactic dose of low molecular weight heparin, or in patients who have renal insufficiency, we use unfractionated heparin. We do not routinely monitor levels in these patients. We started off with doing that, but we realized that was not practical, and we did not notice many dose changes based on those levels anyways. For obese patients, we do adjust the dose of unfractionated heparin based on their BMI. Okay. And all of our patients go out with at least a week of prophylaxis, either low molecular weight heparin or a direct oral anticoagulant. A pill is, of course, preferred. And we do consider extending this prophylaxis in patients who have other risk factors for clots, and I will touch upon that in a slide soon. Then we have level 2 or intermediate dosing anticoagulation. So this is for all our ICU patients. And for floor patients who have a D-dimer level of greater than 6 times upper limit of normal. Again, these are patients who do not have any clinical suspicion for clots, nor a radiological clot. Okay. So the level that we use here is intermediate dose of low molecular weight heparin, or a low standard heparin infusion, as we call it here, where the goal anti-10A level is lower than what it is with full therapeutic dose heparin infusion. Okay. And we try to get Dopplers when possible, especially if D-dimer shows a sudden jump. Before we just put them on level 2, we do get an ultrasound. Many times it's not possible, but whenever possible, we try to do it, and then appropriately assign them to level 2 or full therapeutic anticoagulation. These patients who are on level 2 in the hospital, they go out on 4 weeks of prophylaxis from our hospital. And finally, level 3 is full therapeutic dose anticoagulation, and this is for patients with known or suspected clots. When we first came up with this algorithm, we would use this more liberally in patients, say, who had refractory respiratory failure, thinking maybe they had microthrombosis. But with the data that became available, we backed off some. Our ICU folks were not comfortable at all with leaving our ICU patients just on prophylaxis. So we were using level 2 empirically in them, and we escalate to level 3 only if there is clinical or radiological suspicion for clot. Again, we use low molecular weight heparin or heparin depending on renal function. And as patients, if the patient is on a floor and is on therapeutic anticoagulation because of a clot, if they're stable enough, then we quickly switch them to an oral anticoagulant. And these patients go out on 3 months of anticoagulation, just like we do for any other provoked clots. So, thinking about what is the risk of thrombosis post-discharge. And here, I have to admit, data in COVID population is not as robust as the inpatient data. So this is a study that came out from King's College London, and they commented upon rates of thrombosis in their patients who did not go out on any thromboprophylaxis, and they reported low rates of thrombosis in their outpatients. And since then, a few other observational data have also come out, which say that the rate of thrombosis post-discharge is probably similar to, comparable medically ill patients who are admitted for non-COVID reasons, right? So it is probably fair to say that we need to consider post-discharge thromboprophylaxis. I emphasize only after weighing benefits against risk of bleeding in certain high-risk patients for clots, like patients, say, who have past history of clots, or who have a known severe thrombophilia already, who have history of cancer, age older than or equal to 60, or have immobilization because of any cause, or have had an ICU stay while they were in the hospital. So things to keep in mind. How about patients who are managed outpatient only, meaning COVID patients who just don't require any admission? And the data here is almost non-existent. In fact, we are participating at Emory in a trial that's trying to answer this question. But, unsurprisingly, patients who don't require hospital admission are not as motivated to participate in preventative clinical trials for clots. Right now, what we do is we kind of do an individual risk stratification. Again, the factors that I discussed in the previous slide, we keep those in mind. So a patient who has had clots in the past, if they develop COVID and are being managed outpatient, we do recommend prophylaxis for a few weeks for them, for as long as they have symptoms, and a minimum of 2 weeks. So that ends our discussion on management of and prevention of clots in COVID. Now, just switching gears completely, I want to touch upon this entity called VITT, or vaccine-induced thrombotic thrombocytopenia. Let's see, yeah. So descriptions of a safety signal with vaccines, COVID vaccines, emerged in late February when there were reports of patients who were developing a combination of thrombocytopenia and thrombosis in unusual locations, atypical locations, like the cerebral venous sinus circulation or the splanchnic venous circulation. And this was noticed with AstraZeneca vaccine, which is the Covishield vaccine also in India. Then in mid-April, there were similar reports, few cases. So what is this VITT? And it's vaccine-induced thrombocytopenia and thrombosis, also known as thrombosis-thrombocytopenia syndrome, or TTS, or vaccine-induced prothrombotic immune thrombocytopenia. I think within like 3 months of this being reported, we had 3 different nomenclatures being used in literature already. So this VITT is characterized by, first, low platelets. Right? As you all know, platelets serve an important role in hemostasis. They maintain the integrity of blood vessel wall. They arrest bleeding initially by forming a platelet plug. They stabilize the plug by aiding formation of a fibrin mesh. Right? So that's their role. Right? So one would think that low platelets are associated with bleeding. Right? But in this particular syndrome, low platelets here are associated with clots. Right? And that too, there is a propensity for clots to develop in unusual locations. We don't really understand why this is the case, but that's what is being observed. Cerebral venous sinus thrombosis and splanchnic venous thrombosis. Now, there are also clots like run-of-the-mill clots in legs and lungs being reported, also arterial clots being reported, but there is an unusual propensity for clots in this atypical locations. And just to give you an idea, I mean, outside of vaccine-induced and COVID populations, the incidence of these kind of clots is like 1 to 5 in a million. So they're that rare otherwise. And the third thing that characterizes VITT is presence of platelet activating anti-platelet factor 4 antibodies. Right? So they mimic the autoimmune heparin-induced thrombocytopenia that you're probably all familiar with, where because of heparin binds to platelet factor 4, and that leads to development of antibodies against that complex of heparin and PF4. And that is what activates the whole clotting cascade and causes platelet consumption, right? So here we believe a similar thing is happening, but this is happening unrelated to heparin use. So there is probably something in the vaccine. We don't know exactly what that is, but clearly there is a class effect here because VITT has been reported only with the adenoviral vector vaccines, which are the AstraZeneca vaccines and the vaccine and the J&J vaccine. There was one case reported with the mRNA vaccine Moderna, but there still is just serious doubt if that truly was VITT, because that patient also had some other autoimmune condition that could have explained that. So, barring that one patient, so far, it's just limited to the adenoviral vector vaccines. So if you want to kind of think of pathophysiology, we can talk about pathophysiology of heparin-induced thrombocytopenia because it mimics that. So heparin, like I said, combines with the platelet factor 4, and then antibodies are generated to that complex, which then activates its platelets and other parts of the clotting system. And platelets get consumed in those clots and also have a faster clearance. That is what causes thrombocytopenia. So the important thing about VITT, though, is there is binding of an antibody to PF4 in the absence of heparin. In fact, these antibodies may lose reactivity in the presence of heparin. So the functional studies that are typically done for heparin-induced thrombocytopenia, like the serotonin release assay, they may yield false negative result in VITT. Moving on to clinical features of VITT, and this is from the case descriptions that initially came out. Initially, there was this belief maybe it is more common, more being seen in younger women. But then as more and more cases got reported, the age and the gender predilection did not really pan out. So right now, we really don't know which age groups or if there is any gender that's more affected by VITT. So presenting symptoms, which I think all of us clinicians should be aware of, really the symptoms depend on location of the clot. So headache, visual disturbances, hemiparesis or other focal neurological symptoms, seizures, abdominal pain, back pain, dyspnea or chest pain with PE, limb swelling or pain with a DVT in the extremity. So these will be the presenting symptoms. To establish a diagnosis, if you see a patient who's received COVID vaccine, the adenoviral vaccine, 4 to 30 days prior to symptom onset, they come with a low platelet count, you check an ELISA, HIT ELISA, and that is positive, that really establishes a diagnosis of VITT. Whether a clot is actually present or not, it doesn't matter. You will recall, even with heparin-induced thrombocytopenia, thrombosis is not always seen, right? But we know that condition is so prothrombotic that we preemptively put them on some anticoagulation, right? It's the same thing with VITT as well that is being advocated. So if you see low platelets and HIT ELISA is positive in a patient who's received vaccine 4 to 30 days prior, think about VITT and manage it as such, whether or not they have a clot at that time or not. Then evidence of coagulopathy like D-dimer, low fibrinogen, it may or may not be present. They did not see that consistently across in all the patients in whom this was tested. How about treatment of VITT? So the main thing is we want to address the PF4 antibodies, and we want to start treatment for VITT only after HIT ELISA has been drawn, because if you treat that before that, the ELISA may be falsely negative. And the treatments that have been described are IVIG, 1 gram per kg per day for 2 doses, and or plasma exchange, mainly for patients who do not respond to IVIG alone. Steroids role right now is unclear. So unless things are just not improving, the recommendation is not to give steroids to these patients. Then the second part of treatment of VITT is addressing the prothrombotic state itself. Until we know the pathophysiology better, I have mentioned that this is independent of heparin use, but until we know the pathophysiology better, it is recommended to avoid heparin. Okay. And use any non-heparin anticoagulant instead. Consider anticoagulation for 3 months if the risk of bleeding is low. Again, just like you would treat for any other patient with a provoked clot. And then avoid platelet transfusions. Like I said, this is a prothrombotic state. So we want to avoid platelet transfusions unless there is active bleeding. So this is, just a algorithm that can be followed in patients suspected of having VITT. So if you see patients presenting with a suggestion of thrombosis or thrombocytopenia within 4 weeks of receiving an adenoviral vaccine, check a CBC, D-dimer fibrinogen, and symptom-based imaging to look for clots. And you check HIT ELISA, of course, if they are presenting with low platelets. If all tests are normal, the VITT is unlikely, continue to monitor. If low platelets, but there is no coagulopathy, no thrombosis, and the PF4 antibody is negative, then consider vaccine-induced ITP. We have seen a few cases of vaccine-induced ITP already, and in fact, almost everyone that I know of has responded very quickly to IVIG and a brief course of steroids. Then, if you see low platelets and the PF4 antibody is positive, VITT is diagnosed with or without clots, treat with IVIG immediately. Think about PLEX as the next step, plasma exchange as the next step. Start a non-heparin anticoagulant with a plan to continue for 3 months if the risk of bleeding is low. Avoid platelets. Reserve them for patients who are bleeding. Reserve FFPs and cryoprecipitate for patients who have severe coagulopathy and are bleeding. Now, are there any known risk factors for VITT? Can we counsel our patients, who are maybe anxious about vaccines anyways? Since pathophysiology is related to an immune response to an antigen, classical risk factors for clots, like we discussed earlier, past history of clots or known thrombophilia, etc., they don't apply to VITT. Maybe there is caution needed in patients who have history of HIT, but still unclear. So kind of how do we put this in perspective, right? Especially here, some folks have just an apprehension associated with vaccines. And understandably so. The pace of progress, scientific progress with COVID actually has been unprecedented. Within a year of the pandemic, multiple vaccines have been developed, tested, and made available for public use. I think it's important to put this in epidemiological perspective, right? So the estimated incidence of VITT with AstraZeneca vaccine is about 7 to 10 in a million. Estimated incidence with J&J vaccine is even lower, 3.2 per million, right? But when you look at what benefits we are getting from vaccines, so from UK, this study came about that said one dose of COVID-19 vaccine reduces hospitalization and deaths by more than 80%. In USA, similarly, there are reductions in hospitalizations rates reported with vaccine, 67% and 94% with single and double doses, 2 doses. And we kind of also have to remember risk of death from COVID-19 itself. It's 116 per million as of April of 2021. So vaccination does make sense, despite this rare complication. I think as clinicians, we just need to be ready to treat it if we see it in our patients. With that, I end this talk and I open the forum for questions.
Manila, thank you so much. You kind of covered the entire spectrum in a beautiful way within 35 to 40 minutes. I want to make a couple of comments and then ask you one or two questions using my prerogative. In a very early part of last year, when earlier this year when the vaccine just became available, in one of the Andhra Medical College discussions, in the audience, 2 people from 2 different places said they had a young women who had strokes, went into coma. At that time, the concept of vaccine-induced thrombosis was not there. And I remember in that particular symposium, I was listening, and later on I thought maybe those 2 young people had a vaccine-associated thrombosis. I also read the reason the earlier cerebrovascular thrombosis and splanchnic happened in younger women, but the first group of people who got this vaccine were healthcare workers. So the nurses, other people who are all hospital healthcare employees who are all vaccinated, because the clustering of younger age women, you ended up seeing those, but later on it kind of evened out as millions of people got vaccinated and the age difference and gender preference has gone away. So something that I wanted to just make a comment. I also realized that a lot of people use anti-IL-6, for example, the Acterma, the tocilizumab. Some of them are P450 inducer, cytochrome. So using oral like Xarelto, rivaroxaban, others may be an issue in those because their potency goes up and risk of bleeding goes up. One of the things both in our country, USA, and in India, a lot of these are used together many times. So I just want to caution people when you're using any of these, be careful about using apixaban and rivaroxaban because of the cytochrome induction. So the question I want to ask you is, COVID being endotheliitis, and it causes a lot of endothelial response, and it causes a very high levels of 1 Willebrand factor, and it also causes a decrease in ADAMTS13. Could any of those things be also triggered by vaccines causing this type of thrombosis? Is something that from the beginning I was fascinated by increased 1 Willebrand factor in COVID as part of COVID infection, because not surprisingly because of the endothelial stimulation. So do you have any thoughts on 1 Willebrand factor role? And do you want to make any comments on that? So I will stop here, and because the audience need to participate, there are many experts who are actually listening. They may want to say something. Did we lose you? We need to get you back.
Ravi, maybe you can.
Cheppandi. You want to make it?
I don't know if okay, maybe you can comment. What do you think?
let's just verify. I think we lost her. I'm going to text her on the phone.
Right.
Please.
She said she's going to get back in Sheila's collection briefly.
Okay.
Someone go ahead. Yeah. Emma Chappan Kalpata.
No, I was just asking if you can comment or she can comment on the recent publication, New England Journal, of critically ill patients who got therapeutic anticoagulation didn't make much difference.
Almost manaki anni studies atla unnayi kaani if you look at both the ASH and did we get you back? Okay, and the International Society of Thrombosis, they all are saying there are still some information needs to be teased out at this time. The recommendations are we do not recommend empiric therapeutic anticoagulation in the absence of other indications, even in critically ill patients. I think most of the, for example, Beth Israel for quite some time was using therapeutic anticoagulation and empirical. Even they have kind of stopped doing that. And I don't know what you all do in Baylor. And Dr. Buddharaz is there from Nebraska. Buddharaz, he may have some comments while we're waiting for Manila to come back.
So I'll start with some of the questions Dr. Sharma put. Good evening, Dr. Sharma.
Good evening, Andy.
Budhrazu garu, just one moment. She just called me. She is able to connect with her phone. She should
Yeah.
appreciate that. Let's proceed with her.
Yes, I'm
We'll
sorry.
give you
Lost my power.
Go ahead. I don't know if you listen to me or not, but I'll let you go ahead. Yeah.
Ravi, she may not have heard you, the end of what you said. You might pose the question to her again.
Okay. So I don't know where we lost you, Andy. Let me just go to the von Willebrand factor activation as part of the endothelial, inflammation or endotheliitis, and also the loss of ADAM-TS13 as part of the same process. In addition to losing HDL, will they play any role? Will a vaccine also trigger that kind of response in the endothelium, similar to what COVID infection itself does? So if you want to make any comments on that.
Right. So it is true, even vaccines are known to cause inflammation. And there are, cases of, consequences of inflammation reported with other vaccines also in the past, including the influenza vaccine. So I'm answering the last part of your question first. What can we expect the vaccines to do? Because large number of folks were getting vaccinated in a very short period of time. And you alluded to that phenomenon yourself, Dr. Sharma, about why we saw that age and gender kind of predilection for VITT initially when cases started coming out. So there is a concern right now, at least in the thrombosis community, if the cases that are being reported of thrombosis soon after vaccine, and we are seeing some of those patients ourselves in our clinical practice, and we're trying to make sense of, is this provoked by vaccine or is this an unprovoked clot? So I think we kind of have to look at epidemiological data to answer that question about connection between vaccine and clots. Because it is true, vaccines can activate the inflammation, can cause inflammation, but is the inflammation enough to trigger clots? That's a question I think we kind of have to stay tuned to. I know of some of my colleagues here who have already started gathering data and looking at incidence of thrombosis in populations in these past 6 months versus the incidence that was seen, say, in 6 months in the last year at this time. So I think there is just more to learn there. Right now, again, the jury is out. I tell my patients also, I cannot be sure it's the vaccine that has caused your clot right now. And then the other question that you raised about von Willebrand factor activation and ADAM-TS13 level going down, I know of a few trials that were being done looking at this question itself. Is there any role of plasma exchange in addressing this coagulopathy? And we ourselves ran a trial here at Emory also.
we did see some promising result, but I have to say it's very limited data right now on that. So I think we'll learn more. That's all I know right now about it.
I'm going to open the floor. There is Dr. Buddharaju, and then Dr. Prem Kumar, and then the Zoom user who hasn't, I don't know the identification. So
Zoom user is Dr. Naveen. Dr. Naveen.
Okay. Someone, will you kind of do that so that I won't mess it up? Go ahead, sir. You have.
Dr. Naveen has been there for a while. Please proceed.
Okay.
Sir, namaskaram, sir. Ravi Sharma, sir. Kairam, sir. Padalandarki namaskaram, sir. I'll just, sir. I'll just take a few seconds to deviate of the main topic, sir. It's a good reason for all us, all the AMCOs and AMC to celebrate, sir. Great occasion, great achievement by AMC and our principal, sir. We have just got the ISO 9001 2015 accreditation, sir, certification. Let's all join hands to greet our principal, sir, and his able, very efficient team on this great achievement, sir. Let us all greet our principal, sir, first of all. Kindly permit me to deviate from this topic for a minute. Let's all congratulate our principal, sir.
Okay.
All of you must have read in newspapers and magazines, sir, and in the media. AMC tops so many medical colleges in medical education, quality and standards of medical education, sir. Congratulations, principal, sir, PV Sudhakar, sir. And all the able support that has been given by AMCANA and all.
Naveen Garu, we'll come back to it at the end. Thank you very much for
Thank you,
telling the
sir.
audience.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you for telling the audience the accomplishment in AMC. But let me proceed to Dr. Prem Kumar. He has been waiting.
Good evening, all of you. Actually, it's a lucid exposition on this bleeds and clots. I congratulate her. And the problem today is the dengue fever is rife here, right at the moment. So many cases of dengue are being admitted. So recently we lost a young nephrologist. She thought that her fever is COVID and she took steroids and anticoagulants and she died of bleeding. Actually, the problem is here there is a lot of practice of speculations and empiric treatment of any disease or fever. That's the problem. So I read somewhere that there will be a false positive dengue in IgG, IgM. So if there is such a situation, shall we go for anticoagulation thinking that it is COVID, or shall we withhold anticoagulation and thinking that it is dengue? See, sometimes the clinical picture fits into either one, but the tests may be RT-PCR may be negative. As you all know, RT-PCR is 63% sensitive. So how do we go about it?
Right. That is a great question. And I'm so sorry to hear about the physician who lost her life. Dr. Sharma did discuss that with me earlier today. So patients who are hospitalized with a flu, with a viral illness syndrome, and either you're waiting for the results to come back, or there is a clinical suspicion. When you start anticoagulation in these patients, here we monitor them with daily CBCs, right? So patients who are outpatients and are not admitted, like I said earlier also, in them, it's a very select population that's actually being given prophylaxis in the outpatient setting. We are not doing that outside of clinical trials for our patients. So the use of prophylaxis routinely is limited to patients who are admitted to the hospital. And these are the patients who are getting daily blood counts done. If we see a drop in platelet count and there is no documented clot, we back off, right? So the whole algorithm that I shared with you, the topmost thing actually in the actual algorithm that we have circulated in our hospital says, look at the risk of bleeding every day, evaluate that every day.
So if we notice a downtrend in platelets, we back off anyways. So I would think, doing that will probably decrease the risk of mistreating patients like this, who may be developing thrombocytopenia from dengue, for example.
Thank you.
Thank you so much, Dr. Manin.
Dr. Buddharaju.
Yeah, I wanted to comment on what Prem Kumar was saying. Having seen COVID both in India and extensively in India as well. So there are guidelines issued by, a lot of governmental agencies and health organizations from ICMR to everybody else about what to do and what not to do. Unfortunately, in terms of execution and implementing those algorithms, there's been a disparity in India. I mean, that's unfortunate. We have, and ICMR and organizations there have repeatedly indicated, based on the current evidence and society guidelines, there's no role for any kind of anticoagulation for COVID-19 patients being treated as outpatient. And it still keeps repeatedly happening, where you see anywhere from 2.5 milligrams BID of apixaban to full dose Lovenox injections. I still see that happening in some places. So part of the issue is not following guidelines, and ICMR clearly has clear-cut guidelines on how to treat patients who are not hospitalized as well. Number one. Number two, coming to Dr. Sharma's question about von Willebrand factor. So the von Willebrand factors levels are consistently increasing. Most of the COVID patients, presumably from endothelial injury, I think, and so is factor 8. And we had a small study looking at TEGs in acutely ill COVID-19 patients at Nebraska, and consistently, the von Willebrand factor and factor 8 levels were increased, and the parameters on TEG were consistent with, thrombotic state. So that's basically it. I mean, the take-home point from Dr. Gad is basically there's no role for prophylactic or therapeutic anticoagulation for patients who are not hospitalized, number one. Number two, there has been no survival benefit proven based on the current evidence using either intermediate or escalated doses of anticoagulation, unless there's proven VTE or clotting. There's not enough data to suggest routine use of post-discharge anticoagulation. And all three of these, sometimes are being violated. But that's not because of lack of protocols or algorithms in India. So I want to reiterate to all the people that that's basically the take-home message, I think, from all this.
Thank you. Dr. Gad, additional comment on that topic?
It's very good to hear from somebody who has actually worked in both the settings and can add that, can bring that experience to this discussion. And I completely agree. All these algorithms, I think with anticoagulation in particular, risk of bleeding and what is it that we're trying to gain from using empiric anticoagulation kind of always has to be kept at the back of the mind. And sometimes and as physicians in general, as we say, do no harm is the first thing. So in our over-enthusiasm to, kind of just correcting parameters that may be high when we check them, we sometimes end up harming patients. That is true. COVID-19 is associated with clots, that is there, and more so than with other diseases. And anticoagulation is not without side effects, really. Following an algorithm, and when you use anticoagulants, kind of constantly thinking about what harm can we do if we do not monitor the patient in a certain way has to be kept in mind. So I thank you for those comments, actually.
Now, Dr. G had a question when there was a break. Kalplata.
Yeah, thank you. I was asking Dr. Ravi when you were disconnected from the platform, what is your take on the August publication in New England Journal of critically ill patients who had therapeutic anticoagulation and didn't make any significant difference in the outcome? And there was another paper, I believe, in Chest recently, which had very similar results.
Right. So that's the multi-platform trial I think you're referring to that was published in NEJM recently. Those were the results I presented also. So in the critically ill arm cohort, they found that therapeutic anticoagulation, when compared to prophylactic, did not show any benefit in the number of days of being free of organ support or survival at discharge. In fact, there was a signal for harm with therapeutic anticoagulation in that population. And one of the reasons that's being speculated right now is perhaps, they're already in that stage where any benefit of anticoagulation, they're past that stage. The inflammation and the damage to organs has kind of crossed that stage where anticoagulation could have reversed some of it. But there is limitation of that data. As I mentioned earlier, also 50% of more than 50%, actually 51% of patients who were on the prophylactic arm actually got intermediate dose anticoagulation because that was the standard for those hospitals at that time. So it's clear that therapeutic anticoagulation is no better, but whether intermediate dose still has some value, that question is still out there. So there was this trial from Iran that also I alluded to, the Inspiration trial that compared intermediate with prophylactic dose anticoagulation in ICU patients particularly, and they found no difference. But the whole setup was very different from what we have here in the US. Our ICU folks, like I said earlier also, we meet regularly with the multidisciplinary group here to discuss this data. And our ICU folks have seen a definite decrease in the number of line clots that they were seeing, thrombosis that they were seeing before we implemented intermediate dose anticoagulation for all our ICU patients. And that's the reason why they want to keep that as their default for now. But again, I kind of want to bring this up again. When we do that, we monitor very closely for bleeding when we use intermediate dose or any actually anticoagulation in our patients. I hope that answers your question.
Yeah, I mean,
that's a very good point, and I let Kalplata and you also comment on it. When there is repeated line occlusion, you do treat them at that point. Am I correct, Anna? You can take over.
I mean, that was one of the very early observations in COVID, that we had to change the lines, like dialysis lines, very often. So that's when, I mean, even like Emory, we have 4 hospitals that we practice in. Again, the category 1 and 3, nobody has any questions about that. What you presented. Where people are getting stuck is category 2, where you're kind of, it's not just, prophylactic, you don't have a thrombus. Nobody has any problems with those 2. It's an intermediate group that people are kind of struggling with. I know that one of the hospitals, they do intermediate level anticoagulation in patients, anybody who's in the ICU. Now, again, at least I feel from my experience, patients who are on ventilator in the ICU are not all the same. There may be somebody who's just on high flow or non-invasive, or maybe in the ICU for some other reason other than just respiratory failure. Some other organ may be failing more than the lungs itself. And there are this subgroup of patients who are on ventilator, who are paralyzed, who are prone, paralyzed for 2 weeks, prone for 16 hours, where it's not, although they change the head from side to side, nothing else is moving. So these are different type of procoagulant activity or thrombosis risk in these patients. How often do you get your D-dimers? If a patient is there, let's say 4 weeks, how often do you get D-dimers on these patients to switch, to make a decision?
Right. So, our D-dimer thresholds, more than 6 times upper limit of normal, we got that from the very early Wuhan paper, right? And then very early on, even before we came up with our algorithm, our folks here looked quickly at our data and saw that trend that when the D-dimer was greater than a 6-time upper limit of normal for our lab, there were more patients developing clots. That's the reason why we're still sticking to that, although the randomized trials kind of don't say that D-dimer, they found that played out in the multi-platform randomized trials. So you're right. Just recently, last Monday, we met again as a group, and this is exactly what we discussed. Not all ICU patients are the same. So should we use level 2? Should we limit that for patients who are getting all these lines placed, or we know are going to be in the ICU for long, and not use it in patients, say, who are there for high flow nasal cannula, for example? And again, from our ICU folks, what I get is they are vigilant about looking for bleeds. They have not seen increased bleeds with implementation of this algorithm, and they would rather have a uniform standardized practice just to reduce chances of errors. If you have too many ifs and this and that, there's a higher chance of error. So that's the reason why, because of the benefit they have seen with intermediate dose, they don't want to go back to just prophylactic dose. As far as monitoring the D-dimer level is concerned, right now it's being checked at least twice a week in a lot of patients, even on a daily basis. But we don't make a lot of decisions on fluctuations in D-dimer alone. In the beginning, when all this was very new, we were kind of frantically following that, and we realized clinically it just didn't translate into any meaningful change in management. So other than just using that threshold for escalating to level 2, we don't make a lot of management changes based on just D-dimer level. Say, for example, if a patient has had a jump from a D-dimer level of 3,000 to greater than 60,000, and we've seen that, right? When we see that kind of a jump, yes, clinically, we are just more vigilant. Is there a clot somewhere that clinically we think could have developed? Is there a swelling in the extremity that we haven't noticed? Is there a change in mental status in patients in whom we can still assess it? And we then try to look for evidence of clot there. At the same time, we also look at any evidence of bleed, because as you know, D-dimer goes up not just with clotting, but also with bleeding, right? So that's how we are actually using D-dimer along with clinical things and not just by itself.
Thank you.
Dr. Budhraj,
I just had a question and a comment. So I think the most recent American Society of Hematology guidelines suggest that no decisions of anticoagulants should be based on just coagulation parameters like D-dimers, but they also left it open, saying that decisions can be made based on a comprehensive clinical assessment and degree of suspicion of a clot. So that leaves some flexibility for clinicians to anticoagulate people without actual documented evidence, which a lot of time happens in really sick ICU patients or needing a lot of oxygen or on ventilators. We can't necessarily take them down for imaging studies, or they're in renal failure and things like that. So they kind of left that flexibility for clinicians to decide. So the other question I had was, there was this study, I think it was part of this, multi-center study on moderately ill COVID-19 patients that recruited about 2,200 patients, I think. And there was some benefit in terms of organ support-free days, and based on which they actually stopped that trial, I think. But there was no survival benefit. And I think from what I saw, it barely crossed the threshold of statistical significance. Could you comment on that?
Right, so it's the same multi-platform trial. So there are 3 different trials: the ACT trial, the Active-4A, and the REMAP. Now, these are the 3 trials that came together and compiled their data. So this moderate severity arm is what you're referring to. Yes, in that they did notice benefit with therapeutic anticoagulation over prophylactic anticoagulation. Again, 20% of those in therapeutic arm actually did not get therapeutic anticoagulation, even in that data set. Yes, and they noticed improvement. I think the organ-free support days, the difference was of 3 days, I believe, between therapeutic and prophylactic arms. And I have to think about the survival numbers. I don't remember them off the top of my head. You know, the thing with, again, practically adopting this data. And yes, so that trial was temporarily stopped when it achieved that superiority, but it's still going on. They have added more arms like antiplatelets to anticoagulation because we are also participating in that trial at Emory. So it's still ongoing, but they have, you know, on their part, they think they have answered the question that therapeutic is better than prophylactic for non-severely ill patients. When I talk to my colleagues here, the hospitalists, as I mentioned, you know, earlier during the talk also, for them to put everyone that comes in and gets admitted on therapeutic anticoagulation, they are not comfortable with that because quite a few of those patients, after a brief stay, are fit enough to go back home. They, so again, that question, you know, can we potentially do harm by just over enthusiastically putting all these patients on therapeutic anticoagulation is their concern even now, even with the results of this multi-platform trial becoming available. So we have not adopted that yet at Emory of just putting everyone on therapeutic anticoagulation in the medical floors. We are still using D-dimer and clinical evaluation as a whole also when we make the decision to escalate to even level 2. For those patients.
So the hospitalists, I mean, we're seeing rising cases in our institution right now. And so the last week or so, the hospitalists are asking me this question based on this data, you know, especially for people who are in, you know, somewhere between 5 to 10 liters of oxygen, they're in the inflammatory phase, you know, do we need to consider, you know, escalated doses of anticoagulation, or does the previous algorithm of just prophylactic dose good enough? And I don't see that coming from the American Society of Hematology yet, in spite of this data. That's where
Right, right. You know, despite this data, when I speak with colleagues, and you know, when this data was published in NEJM, in the same issue, there is an editorial about this data where they say, you know, despite all this, we still don't know really what the best way of managing patients is. So you still have to use your clinical judgment. And if you decide to escalate based on, say, increasing need for oxygen, or in our case, combined with that, we do look at D-dimer for a threshold to escalate to level 2. You know, that is still considered reasonable despite this data. So that is what we're still doing.
Dr. G.
You know, I don't see any hands raised or any questions in the chat box. So I just thought I'll continue the conversation. I think Dr. Raju is very right, and I'm sure you agree with that observation as well. Because, I mean, the guidelines are guidelines. But, you know, when you're at the bedside, one thing that has helped us, I'm sure your ICU colleagues, who many of them I know very well, would agree that the point of care ultrasound focus has been extremely useful in the last 18 months. People have been using it like nobody's business because we are so much at the bedside 24/7 compared to before. So I have seen patients full dose anticoagulation when they die, you know, full of clots. And we've also had trials of TPA. I think that's in peer review that was negative. These are, I mean, extremes of prophylactic to, you know, thrombolytics. So I think at the bedside, you have clot, you have all these lines that are clotting 4 or 5 times. We have to change the, you know, the dialysis lines. And sometimes patients go into such acute respiratory failure that on focus, we see very severe acute right heart failure with, you know, D sign and all of those that we see with acute right heart failure, that we just anticoagulate because they're too sick to go down, you know, and we don't know. Sometimes we are right, sometimes we are not. So I think it's it's a different, these are different rules for this disease. And I don't think we know all the answers. I'm glad that a lot of papers are coming out, but still it is the in between, the gray zone is where most people are having kind of difficult, and they're flying by their experience. I know one of our hospitals uses TEG a lot. They used to monitor their anticoagulation and change it based on the TEG value. Then they went to intermediate IV heparin. So then they don't have to really monitor a whole lot and, just use it continuously. So I don't know what the right answer is. We use a D-dimer greater than 3 as our threshold, 3 times our value to raise our suspicion. And we have, like I said, I'm sure all units are using luxury of having focus. So we look at the femorals and everything on probably 80% of patients.
Right. Yeah, no, that's a great point. You're right. There's so many in between, gray zone type of patient issues. It's very difficult it's such a heterogeneous presentation with this disease. It's very difficult to club everyone in these 3 groups and say, oh, this is going to cover everyone. That is true. With all of this, you still have to use your clinical judgment. And I'll say even we looked at TEG and TPA for our patients. There was a publication from our anesthesia group on that earlier, where they did document fibrinolysis shutdown in patients who were doing poorly despite full dose anticoagulation. And we did use TPA, and we got this protocol from another place, I forget where, that was actually running a trial on this.
Denver,
and we did use that in
Colorado, University of Colorado.
Yes, that you're right. Yes. So we did use that in some of our patients who had refractory respiratory failure despite full dose anticoagulation, despite addition of antiplatelet therapy. Some patients did well, many did not. So I think that's the part we still don't know. Despite use of tocilizumab, we still have these patients who just continue to deteriorate. They don't know the answer there. What is it that will help them?
There are 2 on the chat line. One, I think somebody from India should answer. It says typhoid is coming false positive, but NS1 antigen false positive also. I'm not familiar with any of this. And there's another question about TPA, which you already talked about. So if someone knows this question, you can answer that. Typhoid on the chat line. I'm not familiar with that, the point. So I'm just reading it to you.
I have been staring at that question. I didn't quite understand it.
Right. Okay.
The speaker, the person may be available. Could you ask that question yourself, Dr. Maharaj?
It's Mohan Maharaj.
Yeah. Are you there?
Sir, normally, good morning, sir. Thank you very much. Normally, most of the patients, some typhoid positive is coming as when the COVID is positive, but dengue people are not coming false positive. They're actually really NS1 positive. I'm not sure because Prem Kumar sir was telling, that's why I asked that question.
I see.
So I can clarify that. I mean, people in India, clinicians in India, for a long time, when they evaluate fevers, they routinely use a test called Vidal test as a surrogate for typhoid. They don't depend on cultures. And there's a lot of false positive Vidals for any number of reasons. In fact, it's very common to see false positive Vidals. And early last year, when the pandemic started in India, a lot of these patients were actually getting treated for typhoid before being recognized as COVID-19 patients. I think Prem Kumar can attest to that. But this is kind of the season for dengue. We're seeing a dengue surge in some of the southern states like Telangana and Andhra right now. So in general, I think clinicians are already aware of the fact that they need to watch for dengue and not misinterpret and mistreat them as COVID-19 patients. So I think it probably needs some diligence in terms of clinical assessment.
In the few minutes we have left, I have a question for Dr. Garg to see if she could speculate. At the extreme end of the thrombotic disease, there are deaths, there are strokes, people get into a lot of trouble. But at the same time, many people recover and go home, and we have to deal with the long COVID syndrome. Now, in the COVID lung, clearly there is predominant damages coming from microthrombi causing the lung injury. Similarly, I wanted to speculate that a lot of the long COVID symptoms might be related to, and if it's possible, if anybody thought through, for those who received prophylactic anticoagulation, whether or not there is enough data regarding death, there may be less long COVID syndrome and less illness. Speculation just to see whether that makes sense, because any disease that causes death at one end also causes some trouble at the other end. It would not be all or none.
Right, right. So, at least in the US, I believe, unless somebody is actually bleeding or has a high risk of bleeding, everyone is getting at least prophylactic anticoagulation, right? And despite that, people are, 10 to 30% is what they say, people are developing long COVID. So I think in this whole pathophysiology of everything that COVID is causing, there is more than just what can be achieved with anticoagulation alone. There are many different aspects of management of all these, different systemic consequences of COVID-19 infection. That's one. And personally, I will tell you, actually a colleague of mine who had this, she got COVID-19 and just didn't recover her energy levels. And this is very real, a person who is just active, running around children all the time, working in the hospital, goes to not having the energy to even move their arm, for several months after they had COVID infection, experienced COVID infection. And I just did not know how to help them. So we even tried at that stage doing Lovenox empirically, right? Between her and me, knowing what to watch for, etc., checking her blood count before starting that. And we did that for 2 weeks. And this is just one case I'm talking about. Of course, I can't generalize, but there was no improvement at all in her symptoms with that. So, what if we had done that earlier? I don't, again, for admitted patients, everyone is getting prophylactic, except, very few exceptions. So, I can only say there is more to it than just anticoagulation.
All right, Dr. Sudhakar, I think we have just come to the end of your time block. Are you there?
Yeah, I'm here. Ram Mohan.
Yes.
If there are no questions, perhaps we can wind up the session. Thanking the speaker.
Manila, thank you very much for the detail you presented and the time you took. This medical school is thankful to you, but we may call upon you again if the problem doesn't go away in Andhra Pradesh. Thank you very much.
Well, I thank you for inviting me. It has been my pleasure talking to this esteemed audience. And yes, anytime, we learn from each other.
We thank Dr. Ravi Sharma for finding you for us.
Thanks, everybody. You all have a good day.
Okay, good night, Sudhakar.
Yeah, thank you. Thank you very much. We'll end the meeting with that note.
Dr. Garu, can I just ask?
Yes.
Yeah.
The third wave already there in India. Are you expecting it? Are you anticipating it? What is the situation?
Yeah. Well, actually, the Kerala and Maharashtra are seeing increased cases wherein we can assume that the third wave has started, but not so in Andhra Pradesh as yet. And Delhi is much better. And really, there is no third wave if you take the entire country into picture. But in Kerala and in Maharashtra, the numbers are alarming.
So on that note, Dr. Sudhakar, I wanted to share experience here in US. So right now, what we're seeing in US is more than 90% 90% of patients who are being hospitalized right now are unvaccinated. A very small percentage of people who are vaccinated are getting admitted, and even fewer are getting getting sicker with breakthrough infections. So I think even in India, as the vaccination pace goes up, maybe, it's not going to be as bad as what we saw in April, May, June, as the vaccination numbers go up. But that's what we're seeing in US. In fact, in our hospital, more than 90% of people who are hospitalized right now are unvaccinated. So even with the Delta variant, which is very transmissible, that's what we're seeing. So I think rightly so, there's been a big push, both the state as well as the central government to keep pushing on the vaccine.
I mean, in Texas, we have the cases right now are almost as bad as worse than what we saw in July. I mean, we have to increase the number of beds in the ICU. It's really very, very bad. So,
but are you having the same experience, unvaccinated
yes,
versus vaccinated?
99% are unvaccinated people, but a number of our house staff, especially in our group, like critical care and faculty who are fully vaccinated, did contract COVID, but they were not hospitalized. They could stay home. They had fever, cough, some shortness of breath, but it wasn't bad. But definitely we are seeing breakthroughs. But hospitalized patients, I would say 99% are unvaccinated. I think our vaccination rate here is 60%.
Yeah, and we are very glad that the vaccination for 18 plus has started here, because more than 90% of those who are above 45 have been already vaccinated in the district of Visakhapatnam, and so also in this entire state of Andhra Pradesh. Those who are above 45, more than 90% have been vaccinated. Now the state has opened the vaccination for those who are above 18, that is between 18 and 45. I think we can expect a lot more improvement over here and probably avoid the third wave. But looking at the US experience, people are scared here that that may come up over here in Andhra Pradesh as well.
Yeah, I think you should be prepared. I think it's a matter of time. We thought we beat it, and now we are in bad shape.
Well, Israel is the best example, very fully vaccinated. Now they're seeing patients again, and that is the reason why they went into the booster at this time. So
already our hospitals here are giving boosters.
Got you. And Moderna is good in India, except they asked for immunity against liability, and the federal government hasn't given. So Moderna is not being distributed yet in India. Even though they have the approval, everything, it's not being distributed because they wanted vaccine immunity in terms of liability. So
at least here we can go to cvs.com and just schedule and go get a booster.
All right, folks. Thank you so much. Amir, good morning.
Yeah. Thank you very much, Dr. Kalpalata, for those closing remarks. And with that, we end the meeting for today. Thank you, Dr. Ravi Sharma and Dr. Manila Garg. Thank you, Ram, for again conducting this so well. Thank you, one and all.
Thank you.
Thank you, Dr. Garg.
Thank you. Bye-bye.